Welcome to our deep dive, all about pain management.
It's kind of wild when you think about it, how we've gone from just like willow bark to treat headaches to this whole arsenal of meds that target pain.
That's right. And today we're going deep into your nursing class notes on analgesics.
It's a fascinating world, really.
We're talking about everything,
Yeah.
those familiar over-the-counter pills, powerful opioids, even medical cannabis.
A lot to cover.
By the end of this deep dive, you'll have a really solid understanding of these medications, what they are, how they work, and crucially, how to use them safely and effectively.
Yeah, as a future nurse, that's,
Super important.
critical. Absolutely. But first, let's define what we're actually up against. Pain.
Okay, so it's more than just a physical ouch.
Oh yeah, it's a whole body experience. It involves our senses, our emotions, even memories.
So it's not just like how much pain you're in, but how you actually personally experience it.
Exactly. Think of it like, I don't know, spicy food. Some people, they love that burn. Others, a sprinkle of black pepper is too much. That's kind of like the difference between pain threshold when you first start feeling the pain and pain tolerance, how much you can actually stand.
So one person, they might feel the burn from a chili pepper right away,
Right.
while another person might not even flinch.
Right, exactly.
But the one who flinched might be done after just a few bites, and the other one keeps going for more.
Yeah, a perfect analogy. And for you, as a future nurse, this means you have to understand that pain is subjective.
Totally.
What one patient describes as a 9 out of 10, another one might just call it a 4.
Now, my notes highlight this big difference between acute and chronic pain. Why does this matter so much for treatment?
Well, acute pain, it's like your body's alarm system.
Okay.
It's usually pretty short-lived, tied to a specific injury, a burn, a broken bone. It's a signal that, hey, something needs attention.
Makes sense.
Treatment focuses on fixing the underlying problem and,
Providing temporary relief.
Right, exactly.
So like popping ibuprofen for a sprained ankle,
Yeah.
that's managing acute pain.
Exactly. Now, chronic pain, this is more like, a broken alarm.
Uh-oh.
That keeps blaring even after the danger's gone. It can last for months, years even, often with conditions like arthritis or nerve damage.
Ooh, that sounds rough.
It is. And in these cases, it's less about eliminating the pain, completely. It's more about finding ways to manage it, to help the patient function better, improve their quality of life.
My notes mention all sorts of different types of pain too. Referred pain, neuropathic pain, phantom pain. It's like there are a million ways to hurt.
And that's why pain management is such a specialized field. You have referred pain. That's when, you feel the pain in your left arm during a heart attack.
Oh, wow.
Even though the problem is your heart.
Right.
Or phantom limb pain, where someone feels sensations in a limb that's not even there.
Like a phantom itch you can't scratch.
Exactly. It shows just how interconnected our bodies and our brains are when it comes to pain.
Okay, so with all these variations,
Mm-hmm.
where do we even begin to tackle pain?
Well, that's where analgesics come in.
Analgesics.
Yeah, these medications, they're designed to ease pain without knocking you unconscious.
Okay. Though some might make you pretty sleepy, I'm guessing.
Yeah, that's true. Some of them can.
Okay, let's unpack these different categories of analgesics. My notes list opioid analgesics, non-opioid analgesics, and even some miscellaneous ones like adjuvants. What are those?
Adjuvants. Well, think of them as sidekicks.
Sidekicks.
Yeah. They may not be pain relievers themselves, but they can boost the effectiveness of other pain meds or help manage side effects.
Okay.
Like, for example, antidepressants.
Really?
They can actually be really helpful for certain types of chronic pain.
So it's not just about finding the right pain med. It's about finding the right team of medications.
Precisely. And now, let's dive into the big leagues, shall we? Opioids. Opioids.
They're derived from the opium poppy, and they've been used for centuries, but they're serious medications.
Right, and under the Controlled Drugs and Substances Act, opioids are tightly regulated.
Oh, absolutely. And for good reason. They have a high potential for abuse and dependence.
So how do they actually work?
Well, they work by binding to opioid receptors in our brains and spinal cord. Imagine it like.
Like a lock and key?
Exactly. And this binding action, it disrupts the pain signals, essentially telling your brain to, chill out about the pain.
So they're not just masking the pain, they're changing how the brain perceives it. That's powerful.
Oh, it is. And that's why understanding their mechanisms is so important.
My notes list: morphine, hydromorphone, fentanyl, methadone, codeine, and oxycodone. What are the key differences?
Well, you can think of morphine as like the OG opioid.
Oh, yeah. It's used for, moderate to severe pain, often after surgery, or for chronic pain associated with cancer. It's very effective, but it does carry the risk of respiratory depression.
Respiratory depression.
Yeah, meaning it can slow down your breathing, and also dependency.
Okay, so that sounds a little scary.
It can be, and that's why careful monitoring is crucial, especially when starting an opioid or adjusting the dose.
And hydromorphone, is it similar to morphine?
It is similar, yeah, but more potent. Much more potent, actually.
More potent.
Uh-huh. You might be surprised to learn that sometimes a dose of hydromorphone the size of a grain of rice,
Wow, a grain of rice.
yeah, can provide the same pain relief as a much larger dose of morphine.
That's incredible.
But of course, with greater potency comes greater risk. Hydromorphone also has a higher risk of respiratory depression and dependency.
Then there's fentanyl, which is incredibly potent.
Fentanyl. Oh, yeah. Fentanyl is incredibly powerful. It's often reserved for patients who've, developed a tolerance to other opioids or are experiencing severe pain, like during surgery. Super effective, but very high risk of overdose, addiction, and, you guessed it, respiratory depression.
So with fentanyl, even a tiny amount can be dangerous.
Oh, absolutely.
Right.
Which is why proper disposal of those fentanyl patches is so important.
So you can't just toss them in the trash.
No, definitely not. Used patches still contain enough medication to be harmful. You need to fold them in half, sticky sides together, and dispose of them through like a designated drug disposal program.
Got it. Safety first. Now, methadone is an interesting one.
Interesting how?
Well, I know it's used for pain, but also for treating opioid addiction.
Ah, yes. Methadone. It's a bit of a chameleon, you see. It's long-acting, so it stays in the system longer. Makes it great for managing chronic pain.
Okay.
But that same quality is what makes it helpful for reducing withdrawal symptoms in people recovering from opioid addiction.
So that long-acting nature, it's a benefit and a risk then.
Yeah, exactly. There's a risk of accidental overdose if it's not used very carefully.
What about codeine? Isn't that in some cough syrup?
Codeine, yeah. It's a milder opioid, often used for, mild to moderate pain. And as you said, as a cough suppressant, often combined with acetaminophen. You'll find it in medications like Tylenol, #2, #3, and #4.
And are those different strengths?
Yes, different amounts of codeine.
Okay, interesting.
Now, while it is less potent than some other opioids, there is still a risk of dependency, especially with long-term use.
Okay, last one on the list, oxycodone. What's the deal with this one?
Oxycodone, that's another heavy hitter, used for moderate to severe pain. It's prescribed on its own, or sometimes mixed with acetaminophen, like in Percocet.
Okay.
Similar to other opioids, it does carry that risk of dependency and overdose, so careful monitoring and responsible use are,
They're key.
they're really important.
It seems like the takeaway here is that opioids are powerful tools, but they have to be used with extreme caution.
Couldn't have said it better myself. Understanding how they work, their benefits, and also their risks, it's crucial for healthcare providers, especially nurses.
Absolutely.
It's all about finding that balance between providing pain relief and, ensuring patient safety.
So can you break down exactly how opioids work in the body?
Yeah.
You mentioned earlier about binding to receptors.
Oh, yeah. So imagine these receptors as, like tiny docking stations.
Docking stations.
Yeah, in our brains and our nervous system. Opioids like morphine or fentanyl, they fit perfectly into these docking stations. And when they bind, it triggers a cascade of events that eventually leads to,
To the pain relief.
Exactly. Now, different opioids, they fit into these receptors with varying degrees of snugness.
Snugness.
Yeah, think of it like a handshake.
Okay.
Some are really firm and strong, others are a bit limp.
I get it.
So this snugness, this affinity, is what determines an opioid's potency.
Okay.
Some opioids, like codeine, they're weak agonists,
Meaning,
meaning they have a loose grip on that receptor.
so they're not as effective.
Well, they bind, but they don't trigger as strong of a response. Others, like fentanyl, they're strong agonists. They bind tightly and produce, a much more powerful effect.
So fentanyl has that vice grip handshake.
That's one way to put it.
My notes also mention partial agonists. What are those?
Partial agonists, these are interesting. They bind to the receptor, but they don't fully activate it.
So like turning the key in the lock, but only halfway?
Exactly, resulting in a weaker response.
Interesting.
Buprenorphine is a good example.
Buprenorphine.
It's sometimes used for pain management, but also for treating opioid addiction. And it has what we call a ceiling effect.
Ceiling effect.
Yeah, so increasing the dose beyond a certain point won't actually increase the pain relief, but it could increase the risk of side effects.
So it's like trying to force open a door that's only partially unlocked. You're not going to get any further. You're just going to damage the door.
Mhm.
Does this ceiling effect apply to all analgesics?
The analgesic ceiling effect, it's more common with non-opioid pain relievers, but it is a concept worth worth understanding.
Why is that?
Well, it highlights why more isn't always better when it comes to pain meds.
That makes sense. My notes also have this term equianalgesic dosing. What's that all about?
Oh, equianalgesic dosing. It's basically, finding the right balance between different types of painkillers or different ways of taking them. It's almost figuring out how many cherries equal the sweetness of one strawberry.
So they're different,
Right.
but you can still find an equivalent.
Exactly. It's especially helpful when, when switching a patient from one medication to another, or from, from pills to an IV, for instance.
Think so?
So it ensures they're still getting that same level of pain relief.
Now, I have a couple questions scribbled down here. The first one asks if you can give immediate release and slow release opioids at the same time.
You absolutely can. And sometimes it's actually the best approach. The idea is to,
Tackle the pain from two angles.
Right, exactly. The slow release opioid provides that steady, long-lasting foundation of pain relief, and the immediate release is there for those, breakthrough pain flare-ups that pop up.
So it's like having a base camp set up and then sending out a quick response team when needed.
Exactly. A perfect analogy. But of course, this needs to be carefully managed by, by a healthcare provider to avoid any overdoing it.
Makes sense. And my other question asks if you can give other analgesics with opioids.
You can, and in many cases you should. Think of it like combining different spices.
We create a more complex flavor.
Exactly. Each ingredient contributes something unique. Combining pain relievers is called multimodal analgesia.
Multimodal analgesia.
And it has a couple of perks. First, it can really boost the pain relief, allowing you to use lower doses of each medication and potentially, reduce the risk of side effects.
That's brief.
And second, it targets different pain pathways, which is super helpful for, those complex situations where one drug just might not cut it.
So this is starting to paint a picture of how complex pain management can be.
Oh, absolutely.
It's not just about popping pills. It's like a delicate dance.
Oh, dance. I like that.
Between different medications, different mechanisms, and of course the individual patient's needs.
You got it. It's a true collaboration, really, between the healthcare team and the patient.
Now, speaking of that delicate dance, let's talk about some potential side effects of opioids. My notes have a whole table on this, and honestly, it's kind of intimidating.
Yeah, it's true. Opioids do come with some baggage. Side effects. Understanding these potential side effects, it's crucial, not just for healthcare providers, but also for patients, so they know what to watch out for.
Okay. Besides the respiratory depression we've talked about, what else should we be looking out for?
Well, sedation and mental clouding are pretty common, especially, at higher doses.
Why is that?
It's because opioids, they act on the central nervous system, essentially telling your brain to, to slow down a bit. And sometimes we can manage this by just tweaking the dose or switching to a different medication. In some cases, we might even use like CNS stimulants to kind of counteract those sedative effects.
To give the brain a little jolt.
Yeah, like a little caffeine boost for the brain.
I see. My notes also mention subacute overdose. What is that exactly?
Subacute overdose, it's a state of extreme sleepiness and a respiratory depression that can happen with opioid use. It's like your body saying, whoa, too much, and hitting the snooze button.
It's the snooze button.
Yeah, on your brain and lungs.
Okay.
If we suspect this is happening, we might hold a dose or two of the medication and, just see if things improve. And if they do, we might adjust the dose to prevent it from happening again.
So then there's this thing called opioid-induced hyperalgesia, which seems a little counterintuitive. How can an opioid, which is supposed to relieve pain, actually make you more sensitive to it?
It is a bit of a head scratcher, isn't it? Opioid-induced hyperalgesia or allodynia. It's when, prolonged opioid use actually increases pain sensitivity.
It does.
It does. It's like the volume knob on the pain gets turned up. It's thought to be related to changes in the way the nervous system processes pain signals, but we're still learning about it.
So what do you do if that happens? Just stop the opioid completely?
Not necessarily. We might slowly taper the opioid dose to minimize withdrawal, or find that sweet spot where it provides relief without making things worse.
Okay, so we've covered some of the CNS effects.
Yeah.
What about other systems?
Other systems.
I know opioids can cause some pretty unpleasant gastrointestinal issues.
No, absolutely. Nausea and vomiting, they're very common, especially when starting an opioid or increasing the dose.
And why is that?
Well, it's partly because opioids can mess with the vomiting center in the brain, and they can also slow down the movement of food through your digestive system.
Ugh, so you're stuck feeling nauseous?
Yeah, not always. We can often prescribe antiemetic medications to help with that. And then there's constipation, which is very common with opioids. They really,
They slow things down.
yeah, they put the brakes on your gut, makes it hard for things to, move along.
So more meds to combat the side effects of other meds.
Sometimes, yes. We might prescribe stool softeners or laxatives to help things move along, but non-pharmacological approaches are important too.
Like what?
Well, encouraging patients to drink plenty of fluids, eat fiber-rich foods, and stay active as they can tolerate.
Okay, good advice. Anything else about opioid side effects we need to know? My notes mentioned a few more.
Oh, right. They can also cause dry mouth, difficulty urinating, itching, muscle twitches, even mood changes, like dysphoria or euphoria. And it's important to remember that everyone responds to these medications differently.
Okay.
What might be a mild side effect for one person could be a deal breaker for someone else.
Totally. So ongoing assessment and open communication with the patient is key with these medications.
It really is. It's about constantly checking in, seeing how they're doing and adjusting that treatment plan as needed.
Makes sense.
We want to make sure we're providing pain relief without causing unnecessary discomfort or complications.
We've also touched on opioid tolerance and dependence. Can you explain the difference between those? Because I think there's a lot of confusion about those terms.
Yeah, there is. Tolerance is like getting used to the heat. If you move to a hot climate, at first you sweat buckets, but eventually your body adjusts.
Okay, I can see that.
Similarly, with tolerance, you might need higher doses of an opioid to achieve the same pain relief as your body gets used to it. Dependence, on the other hand, is, it's more like needing your morning coffee.
So tolerance is needing more and dependence is needing it.
Precisely. Physical dependence means your body has adapted to the drug's presence. If you abruptly stop taking it, you'll experience withdrawal symptoms. Psychological dependence, this is more about, the mental and emotional cravings and the compulsions associated with the drug.
That I gotta have it feeling.
Exactly.
And opioid withdrawal, that sounds pretty rough.
It can be. Symptoms can range from, physical discomfort, muscle aches, sweating, chills, nausea, vomiting, to psychological distress like anxiety, irritability, even depression.
Wow. So I can definitely see how your role as a nurse is going to be so crucial in, recognizing and managing these potential complications.
It really is. Nurses, they're on the front lines of pain management, from assessing pain levels to, administering meds safely, monitoring for side effects, educating patients, providing support during withdrawal. It's a big job.
Let's do a deeper dive on some specific opioids. We talked about morphine being the OG, and my notes mention a concern about a metabolite called morphine 6-glucuronide. Without getting too technical, what's the issue there?
Well, think of metabolites like, leftovers after a big meal.
Leftover.
Yeah. Most of the time, our bodies clean them up without any fuss. But sometimes, these leftovers, they can pile up and cause problems. Morphine 6-glucuronide is a byproduct of morphine metabolism. It's usually excreted without a hitch, but in some patients, especially those with kidney problems, it can build up and lead to stronger side effects.
So it's like leftover food going bad in the fridge.
That's a good way to put it. It's something to be mindful of, especially when caring for patients with those underlying health conditions.
We talked about hydromorphone being quite potent compared to morphine. Any specific considerations for nurses working with this medication?
One key thing is knowing the equivalent dosing, compared to morphine. This is really helpful when switching between the two.
Okay.
For IV or IM administration, 1 milligram of hydromorphone is roughly equivalent to 15 milligrams of morphine.
Good.
Orally, 1 milligram of hydromorphone is equivalent to about 5 milligrams of morphine.
So it's like comparing apples and oranges. You need to know how many oranges equal the sweetness of one apple.
Exactly.
Good to know when you're the one handling those meds.
Precise dosing is really crucial with, with these potent opioids.
And fentanyl? Anything else to highlight about that one?
Well, it's worth mentioning that fentanyl comes in different forms.
It does.
Yeah. Besides the injectable form used in, hospitals and surgery, there are patches that provide continuous pain relief for several days and sublingual effervescent tablets that dissolve under the tongue for faster absorption.
So the way it's given impacts how it might be misused.
Precisely. Patches, for example, they carry a risk of, accidental exposure or misuse if they're not handled and disposed of properly.
Right. And methadone. Anything specific about that one that nurses should be aware of?
One thing to keep in mind is that it can sometimes cause heart rhythm problems, cardiac dysrhythmias. It's like a little glitch in the heart's electrical system.
Okay.
It's something to watch out for, especially in patients with existing heart conditions.
So again, opioids are powerful and require a lot of attention to detail. Okay, let's switch gears now and talk about what happens when someone takes too much of an opioid, an overdose.
Yeah.
I know there's a medication called naloxone that's used in these emergency situations. How does that work?
Naloxone. Think of it like a superhero. It swoops in and kicks the opioid off the receptor, preventing it from doing any further harm. It binds to those same opioid receptors that drugs like morphine and fentanyl bind to.
Okay.
But it blocks their effects instead of activating them.
So it's like putting a shield over the receptor so the opioid can't attach?
Exactly. It reverses the effects of the overdose, especially that life-threatening respiratory depression. And it's available as an injection, but also as a nasal spray, making it, easier to administer in emergency situations.
So to be a lifesaver in those opioid overdose situations.
It absolutely can. But it's important to remember that it only works for opioid overdoses. It won't reverse the effects of other drugs like benzodiazepines or alcohol.
Are there any risks or any side effects with naloxone?
It's generally very safe, but it can cause withdrawal symptoms in people who are physically dependent on opioids. This can range from things like, nausea, vomiting, sweating, to more severe symptoms like seizures, but that's very rare.
So even though it's an antidote, it still needs to be used carefully.
Oh, always. In overdose situations, they're complex. Getting immediate medical attention is crucial.
Now, let's shift away from opioids for a bit and explore non-opioid pain relief. Acetaminophen, I think probably everybody's heard of it. Tylenol is probably in every medicine cabinet out there.
Probably. It's, it's pretty popular.
So are there things we might not know about this seemingly harmless over-the-counter drug?
Acetaminophen is like that quiet friend who's always reliable, effective for, mild to moderate pain, fever, but there are definitely some things to keep in mind.
Like what?
Well, for instance, it doesn't have anti-inflammatory effect.
It doesn't.
Unlike some other pain relievers. So while it can tackle pain and fever, it doesn't really address that swelling and redness you might see with an injury or with a condition like arthritis.
So it's a good option when aspirin or NSAIDs, which do have those anti-inflammatory effects, aren't a good fit.
Right. It's a valuable tool, but it's not, it's not a one-size-fits-all solution.
So how does it actually work in the body?
The mechanism of action.
Yeah, the mechanism of action.
We're still unraveling some of its mysteries, but we believe it works mainly in the central nervous system by blocking the production of certain chemicals called prostaglandins.
Okay, so it's essentially stopping those pain signals from reaching the brain.
Pretty much, yeah. And it's generally considered safe at recommended doses.
But my notes do mention a pretty big, bold warning about liver damage.
Right. Exceeding the recommended dose can really do a number on your liver.
So even Tylenol can be dangerous.
Yeah.
I always thought it was completely harmless.
It can be if it's not used responsibly. While generally well tolerated, going overboard with acetaminophen can lead to serious liver damage, even liver failure. And it can happen gradually over time with chronic overuse or, more suddenly with a single large overdose.
This is where reading the label carefully becomes super important.
Absolutely.
You might be taking multiple medications that contain acetaminophen without even realizing it.
You could be. It's crucial to be mindful of the total daily dose you're taking from all sources, including prescription meds, over-the-counter pain relievers, even cold and flu meds.
Okay.
And combining acetaminophen with alcohol, that's a big no-no.
Why is that?
It can really increase the risk of liver damage.
Okay, I'm making a note to self. Always double check those labels. What's the maximum safe daily dose I should be aware of?
For healthy adults, aim for no more than 4,000 milligrams per day.
4,000.
Yeah. But for older adults or those with, with liver issues, it's best to stay around 2,000 milligrams or less.
Okay, so 4,000 for healthy adults, 2,000 for older adults, or those with liver concerns. Got it. What are the signs of an overdose? What should people watch for?
Early signs can include things like nausea, vomiting, abdominal pain.
Okay.
Long-term overuse can also damage the kidneys, so regular checkups are important.
And I know there's an antidote for acetaminophen overdose.
There is. It's called acetylcysteine. It helps to protect the liver from damage.
So it's like giving the liver the tools it needs to repair itself.
That's a good way to put it. But there is a catch. It's most effective when given within 10 hours of the overdose. After that, the effectiveness drops significantly.
Wow, so time is of the essence. What about signs of, like, severe toxicity? What would warrant a 911 call?
Well, if you notice a rapid, weak pulse, difficulty breathing, cold and clammy extremities, or changes in mental status, those are all red flags.
Red flags.
Yeah, meaning the liver is in serious trouble.
Okay, so acetaminophen is effective and generally safe when it's used correctly. But it's definitely not something to take lightly. Overdose is a real risk, and knowing the signs and acting quickly is essential.
I agree. Now let's move on to another familiar group of pain relievers, NSAIDs. I'm guessing you've probably popped an ibuprofen or two in your time.
Oh, for sure. Ibuprofen is like my go-to for just about any ache or pain.
Yeah.
So what makes NSAIDs different from acetaminophen?
Well, besides having those anti-inflammatory properties we talked about earlier,
Right.
they work a little differently. They inhibit these enzymes called QOX1 and QOX2, which are involved in making those prostaglandins we discussed.
Prostaglandins.
Right. Think of QOX1 as the good guy.
The good guy.
Yeah, it's responsible for, protecting your stomach lining and other important functions. QOX2 is more like
Like the troublemaker.
the troublemaker. It fuels inflammation.
So by blocking COX2, you're reducing inflammation. But what about those good prostaglandins produced by QOX1? What happens to them?
Because when they get blocked,
Yeah, is there a downside?
that's the trade-off, really. Inhibiting QOX1 can increase the risk of, those stomach issues, like heartburn, nausea, even ulcers and bleeding in some cases.
So you're getting that benefit of reduced inflammation, but you might be trading it for some tummy troubles.
Right. It's a delicate balance, and that's one reason why NSAIDs need to be used carefully, especially in people with a history of ulcers or other digestive problems.
My notes list aspirin, ibuprofen, and naproxen as examples of NSAIDs. But is aspirin really in the same category as ibuprofen and naproxen? I always think of it as its own thing.
Aspirin, yeah, it's like that, multi-talented friend who can just do it all.
Yeah.
It is an NSAA, but it also has this unique superpower. It can prevent blood clots from forming. This is why low-dose aspirin is often prescribed to prevent heart attacks and strokes.
Wow, so it's like a double agent,
Yeah.
fighting inflammation and keeping those blood vessels clear.
Exactly.
But doesn't that also mean that it can increase bleeding?
It can. Aspirin thins the blood, which is great for preventing those clots, but it also means that, you'll bleed more easily.
Makes sense.
So it's something to be mindful of, especially for people with bleeding disorders or who are taking other blood thinners.
My notes flag a serious condition called Ray's syndrome, associated with aspirin use in children.
Oh.
What is that exactly?
Ray's syndrome, it's a rare but serious neurological disorder. It can happen in kids and teens who take aspirin during a viral infection, like the flu or chickenpox.
Oh, okay.
And it can cause brain swelling, liver swelling, leading to vomiting, confusion, seizures, even coma.
That sounds terrifying.
Yeah.
So aspirin is a big no-no for kids then.
Generally, yes.
Ah.
It's best to stick with other options for pain and fever in children, like acetaminophen or ibuprofen, and always consult with their doctor before giving any medication.
Always good advice.
Yeah.
Okay, what about ibuprofen and naproxen? What are their main uses?
Ibuprofen and naproxen, they're like the workhorses of the NSAID world. They're great for, general pain relief, fever reduction, easing inflammation.
Like with arthritis or?
Yeah, arthritis, muscle sprains, even menstrual cramps.
So are they pretty much interchangeable?
They are similar, yeah. But there are subtle differences. Naproxen tends to, stick around in your system a little longer than ibuprofen.
How is it?
Yeah, so it's a good option for those who need that longer lasting relief. It also tends to play nicer with other medications, especially those used to manage, high blood pressure.
So if you need longer relief or you're taking multiple medications, naproxen might be a better choice.
It could be, but like all NSAIDs, they can cause those stomach problems we talked about.
Right.
And there's also a Health Canada warning about a potential increased risk of heart problems with NSAIDs, like heart attacks and strokes, except for aspirin.
I didn't know that. So even though they're widely available, NSAIDs aren't without risks.
It's important to use them responsibly at the lowest effective dose for the shortest time possible.
Good advice.
And be aware of potential interactions.
My notes mention a medication called celecoxib, which is a COX-2 inhibitor. How is that different from the other NSAIDs we talked about?
Celecoxib is the last one standing, you might say.
The last one.
Yeah, it's the only remaining COX-2 inhibitor. It was designed to focus on the COX-2 enzyme more selectively, hopefully sparing those good prostaglandins produced by COX-1 and reducing the risk of stomach upset.
So it's like a sniper, targeting only the bad guy.
A great analogy. However, even with this targeted approach, celecoxib still carries those same cardiovascular risks as other NSAIDs, and it's not right for everyone. For example, people with sulfa allergies, they should avoid this one.
Okay, so it has its place, but it's not a perfect solution.
As we've seen, there's no magic bullet for pain relief.
True.
Every medication comes with its own, pros and cons. It's about finding the best fit for each patient.
Let's switch gears and talk about something a bit different. Medical cannabis. It's a hot topic these days. I know it's still relatively new in, mainstream medicine.
Yeah, it is. The use of cannabis for pain goes way back. But only recently, with the legalization of cannabis in Canada, have we seen this surge in research and interest in its potential medical uses.
Now, my notes mention two main players in cannabis, THC and CBD. What are those exactly?
THC, or tetrahydrocannabinol, that's the psychoactive component of cannabis.
The one that gets you high.
Right. CBD, or cannabidiol, this is non-psychoactive, and it's thought to have a wider range of potential therapeutic benefits.
Okay, so THC is the one that gets you high, and CBD is the one that's thought to be more medicinal.
That's one way to put it. Now, both THC and CBD, they work by interacting with the body's endocannabinoid system.
The endocannabinoid system.
Yeah, think of it like an internal communication network that helps regulate a bunch of different functions, including pain, mood, immunity.
So they're both working on the same system.
Right.
But they're doing different things. How does that work?
Well, THC, it binds to what's called the CB1 receptor.
CB1.
Yeah, which is mainly found in the brain and the central nervous system. This is what leads to those, psychoactive effects, but it does have some pain-relieving properties as well. CBD, on the other hand, it interacts with a bunch of different receptors in the body, including CB1, also CB2 receptors, and serotonin receptors, which are involved in, in mood regulation.
So CBD is more of a multitasker?
You could say that, yeah.
What kind of pain is medical cannabis thought to be helpful for?
Research is ongoing, but there's growing evidence that it could be beneficial for a variety of pain conditions, including chronic pain, nerve pain, cancer pain, even end-of-life pain.
And I've heard it can be helpful for nausea and vomiting, especially for cancer patients.
That's right. Medical cannabis has shown some real promise in that area.
Okay. My notes also mention sleep problems, muscle spasticity, even potential anti-seizure effects. It sounds like medical cannabis has the potential to be a real game changer. But is there enough evidence to back up all these claims?
Well, that's the thing. With medical cannabis, it's still a bit of a Wild West out there.
Wild West.
Yeah, there's a lot of excitement, a lot of anecdotal evidence.
Right.
But the research is still catching up. A lot of the studies, they're small. They have limitations. We need more robust, large-scale clinical trials to really know for sure what it can and can't do and how safe it is in the long run.
So it's promising, but we still have a lot to learn. What about the different ways to actually use medical cannabis? I know smoking is, the traditional method, but my notes mention other options.
Smoking is definitely the image that comes to mind. But there are other ways to get those cannabinoids into your system. Besides smoking, it can be vaporized, taken orally in capsules or edibles, absorbed through the lining of your mouth with sprays or lozenges, even applied directly to the skin with creams and lotions.
So many choices. It's like a whole a cannabis menu.
Right.
I'm guessing each method has its own pros and cons.
Exactly. Each route of administration comes with its own, timeline and its own baggage, I guess you could say.
Okay.
Inhaled cannabis, whether smoked or vaporized, that gets into your system really quickly. We're talking like within minutes, and the effects typically last for a few hours.
So if you need fast relief, inhaling is the way to go.
It can be, but remember, inhaling smoke, even cannabis smoke, it's not the healthiest choice for your lungs. And there's always that concern about, about contaminants, especially if it's not from a reputable source.
So what about vaping? Is that a safer option?
Vaping might be a little gentler on the lungs since it heats the cannabis without actually burning it. But we're still learning about the long-term effects of vaping.
Okay. What about those other methods, like taking it orally or those sprays and lozenges?
Oral or buccal administration, it takes a bit longer to kick in, usually 30 to 60 minutes, but the effects can last for several hours. Topical cannabis, that's, like those balms and lotions, that's mainly for localized relief.
Oh, collapse.
It's absorbed through the skin, and it can help to ease, muscle aches, joint pain, inflammation.
So if I'm sore after a workout, rubbing on a cannabis cream might help.
It might. And the bonus is that topical cannabis usually doesn't produce psychoactive effects because very little THC gets into the bloodstream that way.
Okay, so we have different ways of taking it, different timelines for effects. What about those risks we talked about earlier? What are some potential downsides to using medical cannabis?
Well, like any medication, medical cannabis can have can have side effects, and these can vary a lot from person to person.
Of course.
Some people they sail through with no issues, while others might experience a whole host of side effects. Really depends on the individual, the dose, and how often they're using it.
What are some of the most common side effects people should be aware of? I know people often talk about feeling like foggy or spacey after using cannabis.
Cognitive effects, yeah, those are definitely on the list. Cannabis can affect your concentration, short-term memory, your motivation, especially if you're new to it or using high doses.
So not the best thing to use before an exam or a big presentation.
Probably not.
What about physical side effects? We talked about the lungs. Are there any other concerns?
Cannabis can increase your heart rate, your blood pressure, so that could be a problem for people with heart conditions. Nausea is also pretty common, especially with higher doses or for newbies. And then there's a rare but serious condition called cannabinoid hyperemesis syndrome, CHS for short.
CHS.
It causes these intense recurring bouts of nausea and vomiting. It's kind of ironic considering cannabis is sometimes used to relieve nausea.
Right, so it's like a bit of a double-edged sword. You mentioned potential interactions with other medications, too. What should people be aware of?
It's always best to err on the side of caution, when mixing medications. Cannabis can interact with other drugs that slow down the central nervous system, like alcohol, opioids, benzodiazepines. Mixing these can lead to, increased sedation, problems breathing, even overdose.
So no cannabis cocktails.
Definitely not a good idea. And always, always, always talk to your doctor or your pharmacist about potential interactions before using cannabis, especially if you're taking other medications.
What about mental health? There's been a lot of debate about whether cannabis can trigger or worsen mental health conditions.
That's a very, it's a complex area, and we still have a lot to learn. Some research suggests that heavy or long-term cannabis use might increase the risk of developing mental health problems like anxiety, depression, or even psychosis in people who are already predisposed to those conditions.
So, like, if you have a family history of mental illness,
right,
you might be more susceptible.
You could be. And there's also a concern about a possible link between cannabis use and suicidal thoughts, especially in men.
That's concerning. So mental health is something to be, to be very cautious about. Are there any other risks we haven't touched on yet?
Well, besides the individual health risks, we also can't forget about, about public safety. Impaired driving is a major concern with cannabis.
Yeah, those ads about driving high being just as dangerous as driving drunk are pretty powerful.
And they're right. Cannabis can really mess with your reaction time, your coordination, your judgment.
Makes sense.
Making it dangerous to drive or operate machinery. Think of it this way. If you wouldn't drive after having a few drinks, you shouldn't drive after using cannabis either.
So the same rules apply. If you're using cannabis, don't get behind the wheel.
Right.
What about growing your own cannabis at home? I know it's legal now, but are there any safety issues there?
There are definitely some things to to consider before, before setting up shop?
Like what?
Well, first off, there's the risk of fire,
Okay.
especially if you're using electrical equipment. Mold can also be a problem if you're not, controlling the environment properly. And then there's the risk of attracting unwanted attention. Cannabis plants, they can be a target for theft, so you really need to be security conscious.
So even though it's legal, it's not without its risks.
Exactly. It's really crucial to weigh the pros and cons and take appropriate safety precautions.
Now, your notes highlight some special considerations for using cannabis, especially for certain groups of people. Let's start with children and teenagers. Why is cannabis generally not recommended for those under 25?
Well, the big concern with young people is the impact of THC on their developing brains.
Okay.
Think of the adolescent brain as like a construction site. There's a
Yeah.
lot of work going on, and THC can really throw a wrench into the whole process.
I see.
Exposure during those crucial years, it could have lasting consequences for cognitive function, mental health, even increase their risk of addiction later in life.
It's best to keep it off limits until the brain is fully developed.
Most health organizations recommend delaying cannabis use until at least 25.
25. Okay. What about pregnant or breastfeeding women? Any concerns there?
Oh, definitely. Cannabis use during pregnancy is strongly discouraged because THC can cross the placenta and potentially harm the developing fetus.
Yep.
We're talking about risks like, premature birth, low birth weight, developmental problems,
Mhm.
and because THC can also pass through breast milk, the same advice applies to breastfeeding. It's best to just avoid it altogether.
So it's all about protecting the little ones.
Exactly. The potential risks really outweigh any potential benefits.
You mentioned earlier the importance of, avoiding driving after using cannabis.
Yeah.
Are there any other situations where it's best to avoid it?
It's a good rule of thumb to avoid cannabis before doing anything that requires you to be, to be sharp, to be coordinated, to make sound judgments.
Makes sense.
Things like, driving, operating heavy machinery, or even just making important decisions.
My notes mention cannabis use disorder. What is that exactly? And how is it different from, recreational use?
Cannabis use disorder is it's like getting caught in cannabis's web. It's a clinical diagnosis for when your cannabis use starts to become a problem, when it starts to cause you significant distress or, mess with your life.
So it's more than just enjoying it now and then.
Right. It's when it starts to control you.
Okay.
Signs of cannabis use disorder, they can include things like using more than you intended, craving cannabis, spending a lot of time, getting it or using it, neglecting responsibilities, continuing to use despite negative consequences, and experiencing withdrawal symptoms when you try to quit.
So those are basically the same criteria used to diagnose, addiction to other substances.
Exactly. The bottom line is that cannabis use, even medical use, can become problematic.
Okay, so let's talk about accessing medical cannabis in Canada. No, it's legal now, but how do patients actually go about, getting their hands on it?
It's not as simple as going to the corner store, unfortunately. In Canada, medical cannabis, it's obtained through licensed producers.
Licensed producers.
Yeah. These are companies that are authorized by Health Canada to grow, process, and sell cannabis for medical purposes.
So it's not like getting a prescription from your doctor and just picking it up at the pharmacy?
Not quite. You need to register with a licensed producer and get a medical document from a healthcare practitioner, like a doctor or a nurse practitioner.
Okay.
That basically confirms that you have a qualifying medical condition that cannabis might be helpful for.
And then can you just order products directly from them?
Yeah, usually online or over the phone. The licensed producer will then, ship the products to your door.
Wow. Now, we talked earlier about how different strains of cannabis have different effects. How do patients know which strain is right for them?
That's where things get a little tricky.
Tricky.
Cannabis strains, they're like snowflakes. No two are exactly alike.
Yeah.
The effects can vary a lot, depending on the plant's genetics, the growing conditions, how it's processed.
So those labels like indica for relaxation, sativa for energy, are those even reliable?
Those labels are often used, but they're not very consistent.
Oh, yeah.
A better way to kind of gauge those potential effects is to look at the THC.CBD ratio.
Okay.
Strains with higher THC, they're more likely to, give you that high,
Right.
while those with higher CBD are more associated with, with those therapeutic benefits, but without the mind-altering effects.
So if somebody's just looking for like pain relief,
Right.
they might want a higher CBD strain.
Exactly. It's all about, about finding that balance. And it's important to start low, go slow,
Start low, go slow.
gradually increase the dose as needed.
Now, I have a question here specifically for nurses.
Yeah.
Can registered nurses in Saskatchewan assist with and or administer medical cannabis?
The answer is yes, but there are some caveats.
Caveats.
Nurses really need to be knowledgeable. They need to understand the different ways to administer it, the potential side effects, how to monitor patients.
It's not just about following a doctor's orders. It's about, having the education and the training to do it safely.
Exactly. And there are, institutional policies to consider.
Oh, right.
Some facilities might have, restrictions on smoking or vaping cannabis. So nurses need to be aware of, those rules.
Okay, it sounds like there's a lot to learn about medical cannabis and how it fits into, healthcare. But as a future nurse, it's definitely important to be informed.
I agree. Nurses, they're vital in pain management, and that includes understanding and safely administering medical cannabis when it's part of the treatment plan.
Okay, so let's shift gears a bit.
Sure.
Let's talk about the nursing process for analgesics and anti-inflammatory medications.
Ah, yes. The nursing process, that's like our roadmap, really. It guides us through patient care. It's absolutely essential for managing pain, inflammation effectively. It involves 5 steps: assessment, diagnosis, planning, implementation, and evaluation.
5 steps. Okay, let's break those down, starting with assessment. What does that look like?
Assessment is like detective work, We gather all this information about the patient's pain.
Information like?
Where is it? How intense is it? What does it feel like? When did it start? How long does it last? What makes it better? What makes it worse? Any other symptoms that go along with it. We also want to know their medical history, allergies, what meds they're taking, and any reasons why certain medications might not be safe for them.
So it's more than just asking, on a scale of 1 to 10, how bad is your pain? It's really about getting a full understanding.
Exactly. And we also check their vital signs, blood pressure, pulse, breathing rate, temperature. This can tell us a lot about how severe the pain is and if there are any complications.
And then diagnosis. What's that all about?
Remember, in nursing, we don't diagnose medical conditions.
Right.
That's the doctor's job. We identify nursing diagnoses, which are, they're clinical judgments about how the patient is responding.
Okay.
For example, if someone is in a lot of pain, a nursing diagnosis might be acute pain or impaired physical mobility.
So we're pinpointing the problems that, that we as nurses need to address.
Exactly. And then comes the planning stage.
Planning.
This is where we set goals for pain management, create a plan to achieve those goals, figure out what nursing interventions will help.
What are some typical goals for pain management? Is it always about getting rid of pain completely?
Not always.
Yeah.
While wiping out pain completely would be fantastic, it's not always realistic.
Right.
Especially with chronic pain. Our goals might be to reduce the pain to a tolerable level, to help the patient move around better, sleep better, maybe even reduce their need for opioids.
So it's about improving their overall quality of life.
Exactly.
What about that care plan? What does that usually involve?
The care plan, it's all about strategy. We might use a mix of medications and non-drug approaches to tackle that pain.
Non-drug approaches?
Yeah, things like, applying heat or cold to the area, positioning the patient comfortably, teaching them relaxation techniques like deep breathing or meditation, providing distractions like music or TV, even just offering emotional support and reassurance.
So it's a holistic approach,
right.
Treating the whole person, not just the pain.
Precisely. Pain is complex. It has physical, emotional, psychological components. So, addressing all those factors is really key to effective pain management.
Okay, so we've assessed, we've diagnosed, we've planned. What comes next?
It's time for action. Implementation. This is where we put that, that carefully crafted plan into action.
So this is where the rubber meets the road.
Exactly. This could involve, giving medications as ordered, watching how the patient responds to the treatment, teaching them about pain management strategies, and, working with other healthcare professionals.
Teamwork.
It is. It is. And then, of course, comes evaluation. This step is all about checking our progress, making sure the plan is working, and fine-tuning it if needed.
So we're constantly reassessing.
Yes, we're always evaluating, always adjusting our approach to make sure the patient is getting, the best possible care.
Your notes emphasize patient education as a really crucial element of pain management.
It is.
What are some of the key things nurses should be teaching patients about, about their medications and their different pain relief strategies?
Knowledge is power. Informed patients, they're more likely to stick to their treatment plan and, manage their pain effectively.
That's true. What are some common worries patients might have about pain medications?
One of the biggest ones is fear of addiction.
Yeah.
Especially with opioids.
Right.
A lot of people, they hesitate to take them because they're worried about getting hooked.
So how do you approach that? Do you just tell them not to worry?
It's not about, dismissing their concerns. It's about acknowledging those fears and having an open and honest conversation about the risks and the benefits.
Okay.
We explain that addiction, it's a complex process.
Right.
It involves more than just physical dependence. It's about that compulsive drug use, despite knowing that it's causing harm.
So you're helping them to understand that taking opioids for pain relief, as prescribed, is very different from abusing them.
Exactly. It's also important to manage expectations. We emphasize that pain relief, it might be a journey,
Yeah.
It's not always a quick fix.
Makes sense.
It's often about making the pain manageable, improving quality of life, helping the patient, function better rather than eliminating pain completely.
So setting realistic goals is key.
Absolutely.
What about safety? Any specific precautions patients should be aware of?
Safety is always, a top priority. One common side effect, particularly with opioids, is orthostatic hypotension.
Orthostatic hypotension.
Which is a fancy way of saying your blood pressure drops when you stand up. Makes you feel dizzy or lightheaded.
Like the room's spinning.
Exactly. This can increase the risk of falls, so we advise patients to change positions slowly, especially when getting out of bed or up from a chair. We also tell them to avoid alcohol and other CNS depressants because mixing those can intensify the sedative effects.
Okay, so no standing up quickly, no mixing with alcohol.
Right.
What about those gastrointestinal side effects we talked about earlier? What can patients do to manage those?
Simple things like taking their meds with food can help. Staying hydrated is key. Eating plenty of fiber can help prevent constipation.
Okay.
If nausea is a problem, we can prescribe anti-nausea medications.
So there are ways to combat those side effects without adding even more medications. Anything else patients should know?
I can't emphasize enough how important it is to read those medication labels carefully, especially over-the-counter products. A lot of cold and flu meds contain acetaminophen, so you could easily end up taking too much if you're not careful.
So that read the label advice, it's truly golden. Now, any special considerations for different patient populations, like kids, older adults?
Absolutely. Kids usually get doses based on their weight. And aspirin is a no-no because of that Ray syndrome risk we talked about.
Right.
Older adults, they often need lower doses because their bodies just process medications, a little differently, puts them at higher risk of side effects.
Makes sense.
We also need to be extra careful about polypharmacy in older adults. Host speaker.
Polypharmacy.
Yeah, that means taking multiple medications, which can really increase the risk of interactions and complications.
Okay, so extra caution is needed at both ends of the age spectrum.
Absolutely.
What are some red flags? Things that would warrant a call to the doctor right away?
Well, we've talked about, respiratory depression with opioids. If someone is having trouble breathing or their breathing really slows down, that's an emergency.
And that's when you'd use naloxone.
Yes, if it's available. But even after giving naloxone, you still need to get help. The patient might need further medical attention. Other warning signs would be, sudden changes in vital signs, any worsening of their condition, or pain that just won't quit despite medication.
So when in doubt, reach out.
Always better to be safe than sorry.
We've covered so much today. Understanding different types of pain, exploring different analgesics, talking about their potential side effects, and really emphasizing the importance of patient education.
It's been quite the journey.
It really has. And it's clear that pain management is complex. It's always evolving.
It is. We've come a long way, but there's still so much more to learn.
Absolutely. Well, thanks to you and these incredibly detailed nursing class notes, I feel like I've learned so much today about, you know, about the science and the art of pain management.
It's been my pleasure. As you embark on your nursing career, remember to keep that curiosity alive. Never stop learning.
And to our listeners, we hope this deep dive has given you a solid understanding of analgesics and how they fit into, the world of nursing.
It's crucial knowledge, really, for providing safe and effective pain management.
As you move forward in your career, always remember that, that pain is a personal experience. Listen to your patients.
Believe their reports of pain. Advocate for their individual needs.
And never be afraid to, never be afraid to ask questions. The world of pain management is always changing. So stay curious, stay informed, and, stay dedicated to providing the best possible care.
I couldn't agree more.